Hi, I'm Michelle Adubato. The North Ward Center is committed to educating the public about the importance of community programs that give all New Jersey residents a chance for a better life. That's why we're proud to support the important educational programming produced by the CAUCUS Educational Corporation.
Funding for this edition of One-on-One with Steve Adubato has been provided by the North Ward Center, the law firm of GIBBONS, P.C., PSC&G, committed to providing safe, reliable energy now and in the future. The Turrell Fund, supporting right from the start NJ. The Robert Wood Johnson Foundation, the New Jersey Education Association, and by Berkeley College. Promotional support provided by New Jersey Monthly, the magazine of the Garden State, available at newsstands. And by bestofnj.com, all New Jersey in one place.
This is One-on-One. I'm an equal American just like you are.
The jobs of tomorrow are not the jobs of yesterday.
Look at this. You got this?
Here it is, man. Look at that.
Life without dance is boring.
I don't care how good you are or how good you think you are, there is always something to learn.
Do you enjoy talking politics?
No.
People call me because they feel nobody's paying attention.
Our culture, I don't think, has ever been tested the way it's being tested right now.
Such a good question. High five.
We're pleased to welcome Dr. David Dubin, Chief of Radiation Oncology at Englewood Health. This is, in fact, part of our ongoing series on the future of healthcare. This part is actually looking at medical technology, medical innovation, and its impact on our lives. Doctor, we were talking right before we got on the air about how, when it comes to lung cancer, the technology driving how it's being treated, what we find out, it's critical right now. It's changing dramatically. Talk about it.
It's changing very rapidly, and there's a lot of steps in the process. So, first of all, the patient needs to be found out to have lung cancer. In the old days, we found out when the patient was already symptomatic. Now we find out by having patients being screened. So if a person has a certain amount of history of lung disease, smoking, they should be speaking to their physicians about getting screened, usually once a year with low-dose CAT scan. We're finding, therefore, smaller tumors, and those smaller tumors are easier to cure. Once a tumor is symptomatic, it's very rare that a patient is actually cured.
Right.
Now, we're finding patients who don't feel anything, and the tumors are small enough that they can either be removed or they can be treated with radiation for cure.
But doctor, you also told me that the way you're treating these tumors is different. It's in terms of targeting? Is that
we're able to target moving targets. So
explain that.
Okay, so
what's moving?
Every time a patient takes a breath, the tumor is moving.
So hold on. So if you're looking at someone's leg and that person keeps his or her leg still, then the MRI and then whatever, it's relatively still.
Exactly.
Breathing is different.
Breathing is very different.
Moves.
So we can treat
moves
organs.
What, the lungs?
The lungs are moving every time we take a deep breath. You know, if you think about it, the diaphragm is moving up and down. The lung is moving up and down with it.
So how do you target it if it's a moving target?
That's the trick. So we're doing a technique called SBRT, which is stereotactic body radiation therapy.
Hold on, back up, slow down. It's called?
Stereotactic body radiation therapy. So
is that the Calypso system?
Calypso is used within SBRT.
Okay, break it down, go ahead.
Okay, so what we are doing, first of all, is we have to be able to define where the tumor is at all times. So the patient is breathing up and the lung is moving up and down. We have to know during the breathing cycle where that tumor is throughout. So we have to take a special CAT scan.
The team is actually showing some video as you're talking, so go ahead.
Thank you. So we do a special CAT scan called a 4D CAT scan, where we actually take basically a CAT scan every step of their breathing process, and we can see each step where the tumor is. Then we can decide how we're going to account for the motion. One way is to have the patient breathing freely, but with very little motion of the diaphragm. So we put pressure under their ribs, which is somewhat uncomfortable and not very actively effective in many people, but for some people it works to limit the motion, and we can therefore build in a very small margin around the tumor and treat the tumor to a very high dose.
How does it help the treatment of the tumor?
It helps the treatment by making sure that you're treating the right area.
Whoa, hold on. Are you saying that part of the problem is treating, quote, the tumor, but then also affecting the cells,
absolutely,
the organs around the tumor?
I tell patients facetiously a little bit that my field really boils down to one sentence. You have to treat what you want to treat, but avoid all of the areas that you need to avoid.
Is one of the keys to preserve, if you will, healthy tissue?
Absolutely. The lung is a very sensitive organ to radiation. And most people who have lung cancer have a reason for having lung cancer, such as smoking. So they have lung disease to start with. They have very little lung to spare. So we have to treat a smaller volume as we possibly can.
Doctor, the Calypso system, real quick, what is it again?
Calypso are markers that are actually little radio antennas that are placed by the pulmonologist, the lung doctor, into and right around the tumor. So we can actually use a radio frequency transmitter and receiver to localize the tumor by localizing those markers within 1/10 of a millimeter, 25 times a second. So as the patient is breathing in, we can see where the tumor is moving. And once they move to exactly the right location, the beam will turn on. We can have the patient hold the breath, for example, for 20, 25 seconds. The treatment is given, patient breathes, we do it again. When the patient breathes just the right amount, we tell them to stop and start up again.
The country, where do we rank in terms of cases, incidence of lung cancer?
There are about 300,000 cases of lung cancer a year in the United States. There are millions throughout the world. As people have stopped smoking, we see the incidence go down somewhat, but still people who smoked 30 years ago are still at a much higher risk of lung
So
cancer.
30 years ago they smoked. Last 10 years they stopped. They still have issues.
They still have issues. They have the lung disease from smoking, and the risk never goes back down to baseline.
Why?
There's damage that's done when a person smokes, so that the lung cells that are evolving and dividing, there is some kind of damage that's done that causes them to form tumors.
Let me ask you, when you got into this field of oncology, the technology wasn't what it was. We're talking about the future of healthcare. Did you ever imagine it would be what it is?
This was actually the dream.
What do you mean the dream?
The dream was to be able to treat as small a volume as you possibly could and spare normal structures as well as you possibly could, using all of the imaging, the precision of the technology, and techniques where you could focus beams from multiple different directions into one spot.
Say someone says, you know, with all this technology, with all this research, with all the innovation, the physician, he or she, the oncologist, he or she, is less important, you say?
I think it's more important
because?
to have, first of all, you need to have a team approach. You need to have all the different disciplines giving their input. For example, even in lung cancer, patients usually see a medical oncologist, pulmonologist, the lung doctor. Right. They then have to see a surgeon to determine whether they're surgical candidates, and they see a radiation oncologist.
That's a team.
It's a team, and the team really needs to communicate.
I was going to ask you that last part before I let you go. How challenging is it for clinical professionals in different fields, related fields or not, to be communicating with each other in an effective, efficient, coherent way on behalf of the patient? Loaded question, I know, but we've all seen it. Every one of us who have a family member or we've dealt with it, it's like, doctor, you didn't talk to Dr. So-and-so? Okay, so then you wind up being the quarterback.
Right.
Someone says, well, you need a primary care physician. Now, he or she may be very helpful, but isn't it often the fact that you are the quarterback, the patient?
The patient, of course, has to take some control of their care, but the doctors should be communicating. It's very important that you have a team behind you. You want to have multidisciplinary conferences so that people can really speak together and see the case and make a decision.
One more quick one before you let go. The cure rate?
Cure rate for SBRT for lung is over 90%.
Come on.
Over 90%.
Doesn't it matter as to when it's detected?
That's the point. So when we find them early enough that they can be treated with SBRT, they can be cured.
How many treatments are we talking about?
3 treatments in 3 weeks.
Okay, once a week?
Once a week for 3 weeks. Takes about a half an hour to 40 minutes, and they're done.
Dr. David Dubin, who is the chair of Radiation Oncology at Englewood Health. I want to thank you for joining us in this ongoing series on the future of healthcare, particularly focused on medical innovation and technology. Thank you, Doctor.
Thank you very much.
We'll be right back right after this. Thank you, Doctor.
Thank you.
To watch more One-on-One with Steve Adubato, find us online and follow us on social media.
Hi, I'm Steve Adubato. We're coming to you from Newark, New Jersey, the North Ward Center. This is a series of interviews we're doing as part of a series called Autism, A Different Way of Thinking. We're honored to be joined by Suzanne Buchanan, who is Executive Director of Autism New Jersey, which is?
A nonprofit organization that serves the entire state. We have an 800 line, 800 for autism, where parents and professionals can call and get all sorts of information. We educate and inform the community. We try to shape public policy. And if you have any questions about autism, we encourage people to call us.
Here's what's interesting. As we were prepping for this series, Suzanne, here's the thing that kept hitting me. Yeah. What is a different way of thinking? How have we been thinking about it, and what should we be thinking about autism?
Well, I think, one of the advances in the last few years is that we're looking at autism not just as an educational disability that affects a child during the school day, but as a disability that needs behavioral treatment 24/7 during all waking hours.
What does that mean? Give me an example.
Of behavioral treatment?
Yeah.
Sure. So, any socially meaningful goal, right? Like if you have a young child with autism who has very limited language or he's not playing with his brother or sister. So we're going to go in and observe that child, see where the skill deficits are, identify areas that they can make little improvements and shape and reinforce those skills along the way. So it's an incredibly complex situation behind the scenes in terms of how the treatment is designed, but for the child, they just experience it as fun.
Let me try this one. New Jersey versus the rest of the nation when it comes to A, diagnosing autism, and B, helping those dealing with autism.
Sure. I think the good news is that we're a leader in this country. In terms of the prevalence rate, right here in Newark, we have Dr. Walter Zaharodny, who's one of the principal investigators for the CDC prevalence.
The Centers for Disease Control. You're talking about the federal government's role in this?
Yes, exactly. So New Jersey is often one of the 10 to 15 or so states that is included in their federal prevalence estimates. And New Jersey is either the highest or the second highest, depending on the year, that the publication comes out.
Number of cases.
Exactly. And so right now we're at 1 in 34. And so people constantly ask, well, is there something in the water? Is there something in the environment? And none of those hypotheses have been vetted out. None of them have been supported. But what Dr. Zaharodny thinks is happening too is that we have, as he says, a mature network of advocacy organizations and parents sharing information with other parents. And so I think with organizations like Autism New Jersey and our sister disability organizations, continuously putting autism at the forefront, making it a conversation, as early as possible in the pediatrician's office, at parent play groups, right? That we're doing a better job identifying kids as early as possible.
Let's talk about this whole question of urban, suburban communities. Sure. How autism is diagnosed, A, but also treated again. Because, by the way, we're having a forum, a panel discussion with, I believe, 10 experts dealing with autism, all different perspectives. You happen to be one of those experts. And we're also going to be joined by the Commissioner of Health in the great state of New Jersey, Dr. Elnahal. Urban, suburban disparity?
Yes.
Describe it.
So the good news on the prevalence front is that we're doing a better and better job identifying kids from ethnic minorities. And in fact, this is the first year that New Jersey closed the gap, right? Where typically kids from ethnic minorities were underrepresented in those prevalence numbers, but we've caught up. So
what does that mean, underrepresented?
So
does that mean that there are, in fact, more children from urban minority communities who have autism that are not diagnosed or something else?
It used to mean that, right?
What does it mean now?
So now we have the same prevalence numbers of kids with autism that we would expect given the distribution of different ethnicities across the state. Whereas, so the hypothesis is that autism affects all socioeconomic, all ethnic groups at the same rate. But years ago, we weren't seeing as many kids of ethnic minorities as we would have expected, right? And so with the most recent results, we saw that we actually caught up and we are doing a better job identifying, we think, all of the kids.
Why does that matter? Why does it matter to identify those children earlier on? And we happen to be in Newark, it could be Patterson, Jersey City, Camden, Philadelphia, we're seeing in lots of different states, but in urban areas. What is the difference as to when you diagnose a child with autism?
It's huge. It's life-changing, right? So the earlier you get to a kid, the earlier you can assess their behavior and try to improve their behavior, the better prognosis they have. The more skills they'll have, the less challenging behavior they'll have because they'll have better ways of communicating and getting their needs met. It can absolutely be life-changing. They get into preschool sooner instead of just maybe, kind of flailing through those years and going to school at 5, and then the gap between them and a typically developing child is even broader. So we just need to get to kids as early as possible, and we need to get parents connected to information, resources, services, funding streams.
Yes, stay on that.
Sure.
Because in prepping for the show, the thing that kept coming up was that somehow there was also a disparity between how urban parents, some urban parents, versus wealthier folks in suburban communities, whether it's New Jersey and or other states we're seeing, in terms of access to information, knowing where to go to get help, actually having services in their community. So diagnosing it is one thing, getting help, isn't that the other part of the equation?
Absolutely, absolutely. And I will go more into the urban, but I got to tell you, even in the autism community, like in suburban areas, very well educated, very well resourced parents are still struggling. So imagine how much of a struggle it is for parents in urban communities.
What are they struggling with? Break that down. You deal with it every day.
Sure. So years ago, I remember meeting a couple. The father is a gastroenterologist and the mother is a nurse. They're in the medical profession. They go to their colleagues. They say, we think our son, is exhibiting the signs of autism. Where do we go for an evaluation? And this wasn't that long ago. And they kind of got thrown around for a few months until somebody told them about us. And we said, okay, these are the people in your area who are experts in diagnosing autism. These are the people you go to. If you want a second opinion, here you go. Here's how to try to negotiate with the wait list,
You
right?
did that for them.
Yes.
Two medical healthcare professionals.
And that's why I just
So what about everyone else?
I feel like the entire autism community is underrepresented in some way. And then of course, individuals with autism and their families in urban communities are even doubly underrepresented. So that's one of the reasons that we're working with the state to try to get Medicaid to cover ABA treatment and
Well, hold on.
So,
We've got a minute left, but go back to that. You're trying to get the state of New Jersey to do what?
to cover treatment for autism for families who are on New Jersey Family Care.
Because now?
There was federal guidance a few years ago, and New Jersey is making good on its promise to offer that. So they're working on the details.
Is there coverage or not?
There is currently some coverage.
Enough?
No.
This is a public policy question.
Yeah.
Last part, public awareness.
Yeah.
Degree of empathy, if you will, concern.
Yeah.
How much progress in the last 5 to 10 years have we made in terms of public awareness around autism, what families are dealing with, what those who have autism are dealing with?
Right.
How much better are we or not?
I think it's one of those things, like any complex issue, we've made a lot of progress, but we still have a lot of room left to improve. We hear stories probably on a weekly basis or so from families where there was a really good first responder or, just a stranger in a supermarket when their son had a meltdown. People are, as we like to say, we chose a theme for Autism Awareness Month. It's called Choose Kindness. Like in that first moment when you see something unusual, you're not sure why that person is acting that way, just take a deep breath. Choose kindness. Just think, okay, if you were in that person, maybe that parent's shoes, what would you do? Can you offer to help or should you just step away? There's no judgments needed. Everybody has their own challenges in life. And if you can be part of the solution, all the better. But just to choose kindness.
You're part of the solution every day, you and your colleagues, and you honor us by joining your other colleagues in this forum dealing with autism, a different way of thinking. And thank you so much, Suzanne.
Thank you.
Appreciate it.
To watch more One-on-One with Steve Adubato, find us online and follow us on social media.
Steve Adubato, I'm here at the Healthcare Foundation of New Jersey, and it is my honor to introduce the leader of that team, Marsha Atkind, who is a person who, we started this conversation, I don't know, a year ago?
Yeah.
We just finished a forum, not to air, but we interviewed every person who was part of that forum, called Breaking the Cycle of Teen Abuse and teen bullying. And I just said this to you, trust me, there's a question here. It was a hard conversation to have.
It was a very tough
Because?
conversation to have. Well, first of all, I think that people are coming from it from different perspectives.
We had educators, we had people who run not-for-profits, people who are psychologists.
And we had people who represent different communities who are the subjects of bullying. Yes. And I think that even though there are some things that happen in general, that are the same in all of those situations, there are some things that are different.
We had folks from the LGBTQ plus community.
Right. We had somebody who had recently lost a child as a result of online bullying and
Suicide,
perhaps
12 years old.
Yes, 12 years old.
12 years old.
We hear that far too often. I mean, it's horrifying. I think that what she said had a lot of validity, which is that online platforms magnify bullying and make it much worse. It used to be if you and I and a couple of other people were together and somebody said something hurtful to someone else, it really hurt the person who was the target, but it was confined to the 4 or 5 or 2 or however many people were in the room. With social media, it's multiplied. It could be out in the whole world. Everybody in high school or everybody in junior high school could see that. Their parents could see that. And it never goes away. It lives there forever.
The other part of that conversation, by the way, we are only able to do what we're doing because the Healthcare Foundation committed resources to our initiative, plus a range of the other folks who are part of this conversation, not-for-profits, and others who are not. My question is, why is this, teen bullying, teen abuse, and elder abuse, which we'll do an additional program on, why is that the purview of the Healthcare Foundation of New Jersey?
Well, we've discovered...
I shouldn't have asked that after we got the grant. I didn't ask that before. But I am curious, like, why is that part of the...
So we've learned over the course of the 22 or so years that we've been around that mental health and physical health are totally connected to each other. That people who have ongoing mental health issues, chronic mental health issues, tend to live 20 years or so less than people who do not. That children who have adverse childhood experiences tend to have lots of mental health problems and physical health problems as they grow up. And so you can't be a healthy person if you're not mentally healthy, if you don't take care of the issues that, most of us have some issues. It's a question of how many and how serious they are and whether we can get help for the things we need help for.
But the part of the conversation, adverse childhood experiences, we actually check our website. You'll see it come up right now. We actually did, otherwise known as ACEs.
Right.
We did a comprehensive series of interviews down in Princeton, at Morven, I believe, the First Lady and others talking about this. So what Marsha's talking about is so critically important. The thing that struck me about the conversation is that when we started talking about solutions, potential solutions, well, the schools need to, administrators, principals, teachers, they need to be the ones. No, starts in the home. And is it?
So I think the problem is that there's not a magic bullet.
Please
right?
share.
I don't think that any one of those institutions or groups can solve the problem. I think that the problem is multifaceted. Parents have to be taught how to parent and how to react when their children are bullied or are the victims of dating violence or anything like that.
Or are the perpetrators of.
Or are the perpetrators of the same, exactly.
Oh, listen, no, but come on, don't make a big deal about my kid who did that. What?
There's nothing wrong with my kid. It's your kid who was, the bully.
Can't your kid take it?
Yeah, exactly.
Just teasing.
Exactly.
All the wrong
so
messages.
We have to own it. We have to, the stigma has to be erased, and we have to know that all kids, most kids, maybe all kids, do difficult things sometimes, or are the butt of difficult things. And we have to help them get beyond that behavior. We have to figure out why they're doing it, or why it's happening to them, and help them, whichever side of that equation they're on, we have to help them. So I think that's our role as parents, okay? Schools need to understand much better how to identify behaviors that are when a kid is troubled. There was a really interesting show at Lincoln Center a couple of years ago called Pipeline, okay? And it was about the school-to-prison pipeline. And one of the incidents in the show was that a kid, a really good kid, okay, threw a book at a teacher one day when she asked him why he didn't bring his homework in on time. Now, why didn't he bring his homework in on time? That was really the question. His parents had had a very difficult fight the night before. I don't remember whether it had become violent or not, but it was a very difficult fight. And he was really upset by that fight, and he couldn't do his homework. So when the teacher asked him why he didn't have his homework, he reacted emotionally, and he threw the book at the teacher. Now, should he have done that? Of course not.
What coping skills did he have?
Of course not. But wouldn't it be wonderful if the teacher, instead of having him suspended, had either been able herself or had called in a counselor in the school to find out what was motivating this kid? Why did this kid do this? These are things that people in the schools have to learn to recognize and to cope with, and to create an environment in the school that's trauma-informed. That where they can recognize
they know what to look for.
They know what to look for, and they know how to deal with what they find, not just what to look for.
By the way, if you want to find out about another aspect of abuse and bullying, go on our website, you'll see it right there on elder abuse. We looked at that. By the way, give folks a real quick sense. I know we did teen abuse and bullying today. Elder abuse so important because?
Because it's important no matter how many elderly people are abused, but we do have to understand that the population is aging, that more and more people are in the position where they're becoming frail, they're becoming isolated, and they're at the mercy of people who take advantage of them financially, physically, who neglect them, who get frustrated and angry and take it out on them because they're difficult to take care of sometimes. Right. And again, we have to teach caregivers how to cope with people. We have to teach medical personnel, sometimes even people who do people's hair, to recognize when somebody's been abused and to do something about it.
Marsha, thank you for allowing us and so many other not-for-profit organizations to try to be a part of the solution of breaking the cycle of abuse and bullying. Thank you.
Thank you.
One-on-One with Steve Adubato has been a production of the CAUCUS Educational Corporation, celebrating over 30 years of broadcast excellence. Funding for this edition of One-on-One with Steve Adubato has been provided by the Northward Center, the law firm of GIBBONS, P.C., PSC&G, the Turrell Fund, supporting Right from the Start NJ, the Robert Wood Johnson Foundation, the New Jersey Education Association, and by Berkeley College. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area.
The Northward Center was founded on the vision that community is connected to neighborhood stabilization, and neighborhoods need a place for kids to play. That's why we're building a recreational complex in the heart of Newark. Unfortunately, inner-city youth development programs are dwindling. We want to expand on our promise and build a place where kids are welcomed and doors remain open. The Northward Center, building a better community, 48 years and counting.